I'd like to share with you now the standard of care treatment for some common procedures and also address some misconception we have about some of the common procedures that we encounter. This is one of those. Take a look at this left maxilla on this patient, and we're going to use this as an example of one of the common misconceptions. This is a mucogingival line, as we had mentioned previously. This is all attached gingiva, where the mucoperiosteum is attached to the bone. So you have the gingival mucosa, and then you have the periosteum, and then you have the bone, and then you have the alveolar mucosa here that's loosely attached, so you can actually lift this off of the bone and move it around. When using our periodontal probe and evaluating whether we can do root planing curettage and periosutic placement, or in our case, doxyrobe placement, when we're placing that probe, if it stays within this zone, which is coronal to this mucogingival line, and we have an abnormal pocket that bleeds, that's an indication to clean this pocket out, clean the root, and then if we have it, we can place doxyrobe that will enhance the ability of this tissue to reattach to the tooth structure. If we're beyond this gingival margin, or this mucogingival line, periodontal probe carries beyond that, this is all going to be bone loss here. This is likely going to be an extraction at this point. So commonly what we see in practice is people placing that probe, it goes up beyond this margin, they clean it out as good as they possibly can, and then they place a lot of doxyrobe in here, and that does absolutely nothing to prevent the progression of this defect. It will continue to progress, the bone will continually be lost over time, and eventually this tooth will become mobile if the patient lives long enough. So when we're doing root planing and curettage and we're placing doxyrobe, we're confined to the attached gingiva only. So we'll walk you through that and show you exactly what we mean, and look at the anatomy a little closer here, because this is a very common procedure that's very uncommonly misused very commonly. So we place a periodontal probe. We have a 5mm pocket in that area that I just showed you. It bleeds when it's probed. And so this is the instrument that we're going to use to clean out that inflamed granulation tissue that is in that pocket at its base, and also attached to the lining of the gingiva in that pocket between the gingiva and the tooth root. So in order to be able to determine what side of that instrument to use, in that there's only one of these blade margins that actually cut, we need to look at it from a head-on standpoint with the toe facing us with the instrument perpendicular to us. And if we look up closely, you can see the toe is pointing at us. We have an angulation change between this blade and this blade that's somewhat in this orientation, where this blade is closer to the sharpening stone than this blade. Every one of these periodontal curettes have this same orientation in one respect or another, either with the lower end on this side, or if you turn the instrument around on its other end, the lower end will be on this side. That is the cutting edge, and that's to be used on the tooth root for your root planing portion of cleaning out that pocket, and it's to be used on the lining of the gingiva and the base of the pocket when you're cleaning out and doing your subgingival curettage. So here's a cartoon depiction of the tooth root. Here's debris on that tooth root, and so the root planing portion of that procedure is by taking that periodontal curette, using the sharp edge and literally scraping that dentin on that tooth root and eliminating that debris to clean that out.